other things. So what we want and what you all have asked for is, how do you communicate with somebody who has dementia? Tell me a little bit more about strokes and how does that relate to dementia? Again, vascular dementia is one type of dementia, and there are different ways to manage it. So we have with us a neurologist who specializes in neurologic rehabilitation, and she's going to tell us a little bit more about that. So Dr. Barrett.
Well, thank you so much, Dr. Parker. It's always such a joy to be with you all. Really exciting. I wish I could see everyone. I can imagine you all out there, and I loved that exercise session, as I know all of you did as well. It was exciting to move my body a little bit. I am going to put up some slides, but first I'm just going to say that, as Dr. Parker said, I am the director here of the Center for Visual and Cognitive Neurorehabilitation at the Atlanta VA here on Claremont. And I also work in neurological rehabilitation in the Emory system. Today, I'm a little bit in both of my hats because I'm going to introduce introduce our discussion about stroke and its relationship to thinking and mental issues by talking about rehabilitation. So let me put up something to get our conversation started. Something that I guess is my little public service announcement about this. I am, as Dr. Parker said, a specialist in thinking and cognition, but I'm also a specialist in rehabilitation. I'm a Pizza Hut and a Taco Bell of stroke and neurology. So a rehabilitation and cognition. And something that always troubles me is a lot of people who had a stroke. I know a lot of you know somebody who's had a stroke, who's been in the hospital. A lot of them leave the hospital without a plan about what comes next for rehabilitation treatment. And actually, around the corner here at the Center for Disease Control, they told us about 14 years ago that only about 3 people out of 10 who've had a stroke actually have rehabilitation. They actually get therapy. So if there's one thing that you get from my little conversation with you this morning, it's this afternoon, sorry. It is that rehabilitation is available for you, because unfortunately, over the next 10 years until 2017, that number only went up to 6.5 out of or to 3.5 people out of 10 who were getting rehabilitation. So in 2007, it was 3 people out of 10. In 2017, only 3.5 people out of 10. So not enough people, because at least probably 5 or 6 people out of 10 who've had a stroke in the hospital, even if they're walking out of the hospital and able to get back home and able, resting maybe, but able to get back to a lot of their activities, almost half or 60% of people who've had a stroke can benefit from some rehabilitation, because a stroke basically is a heart attack of the brain. It affects the brain and its functions, and rehabilitation can help with any of the functions that stroke affects. So the one we think about the most is strength and movement, with balance and walking. So if people feel a little bit off balance after a stroke, they might say, oh, I'll get better, it'll be okay. Take advantage of the rehabilitation available, and Medicare and insurers will provide that rehabilitation to any of us. So it's available, and it really is helpful. There's really a lot of information showing that it's helpful. But also functional activities. I mean, if cooking seems to be a problem, if we feel clumsy even when we're doing things like playing sports with our kids or our grandchildren, when we're doing things like self-care, like getting dressed, bathing, getting in and out of the shower, if we're experiencing new problems, then really rehabilitation can be helpful. And even for sensation or numbness after a stroke. So oftentimes if folks have a stroke, the opposite side of the body might be weaker, but also they may have some numbness. And that may affect their ability to do things. Swallowing, I think most of us know that we can seek rehabilitation treatment for that, but we really can. And as I think all of you are experts about, thinking and mental function and communication, those are all functions of the brain, and rehabilitation can help with that. So I'm going to give kind of a very, very brief overview, kind of to give you a sense of where we go if we're looking for that. So in general, when people have strokes that affect the language areas of the brain, they can have problems with communication. We call that aphasia. It's a fancy word. And there's actually a national association, which is partly people with aphasia and their families and advocates, and partly professionals that have really put forward, hey, this communication problem is not a problem of intelligence. It's a problem of using language. Just, I have trouble using language if I'm in a country where I don't speak the language. And in the same way, people who have aphasia, their ability to utilize their native language has been changed. And really, a lot of people do not seek therapy, speech language therapy. And speech language therapists are experts in a lot of different areas related to cognition. You're going to hear from Lila Hartley, who is such an expert. Another problem, though, that people can have after stroke is called spatial neglect. And that's actually a problem with the three-dimensional interaction we have with the world. So we have this thing where, if we're moving and our body is moving, and even if the space around us is moving, we can still grasp things effortlessly that we need to interact with in the world. And why is that? We kind of have a GPS in our brain that manages this stuff. But if that GPS is damaged, and oftentimes it's the right side of the brain that controls that, and the left side of the body might be paralyzed in people who have this problem, the simplest movements and actions can be difficult. So here at the bottom of the slide, you see a woman who's using her wheelchair and she can't help herself. She's sitting or kind of sideways. And you'll see these folks who have spatial neglect, they have trouble looking us in the eye. They have trouble looking over to the side of space where their arm is paralyzed. And they can be inaccurate when they get dressed or when they're shaving, when they're doing things. And here on the top, we see a gentleman who has tried to put his glasses on. However, when he puts on his glasses, this is why it's not only a visual problem. We need to use this 3D, GPS in our brains. And when we put on our glasses, we can do so again effortlessly because we're able to use that brain GPS. And if we're not, what happens oftentimes is that the glasses are up too high. And you see he has this thing called the hanging eyeglasses sign, where his eyeglasses are up too high. Anytime you see that in a family member, that could be from this type of stroke-related problem. An occupational therapist or even a low vision therapist, if it's affecting vision and people are running into things, can be very helpful. So these are some examples that we see in kind of textbooks. If you have a piece of paper and there's little chicken scratches on it, the person with this problem, spatial neglect, can't find the chicken scratches on the left side, only the ones on the right side, and the person is trying to mark them out. And here the person is trying to copy what's on the left side here, and you see that what's on the left side is getting left out. So that's, again, this problem called spatial neglect. Now, these are not rare problems. These problems, aphasia that we were talking about, communication problems, about 4 out of 10 people. So this is since April of this year in Emory University Hospital in the stroke unit. And we have a person who goes to the bedside and helps people to be screened. About half of people have this problem with spatial neglect, but about 8 out of 10 people are having problems right after stroke with their memory. Excuse me. And other people are having issues with confusion or with depression. So these are all problems for which we can seek some help. And these memory issues, as we said, they can be trouble getting information into memory, out of memory, storing it. People oftentimes tell me, oh, I have short-term memory issues, but even those issues can cause problems such as driving accidents actually are common in people who have short-term memory issues after a stroke. Falls. These are all the problems that we see in our loved ones who have other forms of memory problems too, like Alzheimer's disease. However, we can more commonly see in people with stroke that, for example, falls, collisions, vision problems, for example, might happen. And it's very difficult, as you all know, if you have friends, relatives, and loved ones who have stroke, to advocate. Oftentimes people do have depression, as we mentioned, and so they may struggle. And so really accessing the community-based resources, including rehabilitation, can be very challenging. So I'm just going to end by talking a little bit about some of the professionals who can help with this. And people like myself, not all neurologists are trained in rehabilitation, but a physiatrist is a doctor who's trained in rehabilitation medicine. There are psychologists who are trained in rehabilitation medicine. Neuropsychologists and rehabilitation psychologists are some of them. And then there are the therapy professions, speech language pathology that we'll hear from, occupational and physical therapy, and brain injury specialists as well. And then other therapists who work in other areas such as recreational therapy, music therapy. And we should be aware that you're going to hear from Lila Hartley, not every speech language pathologist is Lila Hartley. Other speech language pathologists may be more specialized in autism, in school speech language therapy. So just like as doctors are different, therapists are different, and feel free to ask. And something that Dr. Hartley and I were just talking about is, if you're curious about therapy, if you think you might benefit from therapy, nothing says that you can't call a therapy group. So if you see a therapy kind of storefront near where you live, you can call or you can drop in and say, look, I think I might be somebody who could use some therapy. You can bring your mask and come into the therapy place and say, look, I have a loved one who's had a stroke. I've had a stroke. What would I need to do to qualify for therapy? And then, do you have somebody who can help me with memory? Do you have somebody who can help me with aphasia? Somebody who can help me with spatial problems? And consider, even if your insurance is a barrier, consider discussing self-pay options. I know that sounds expensive, but it may only be a couple sessions, for example, to learn to use an app on your phone to help with memory or with reminders. And there are programs at many colleges that offer reduced cost therapy. So if you're wanting to get therapy to gain strength, to improve your balance, you may be able to go to a physical therapy program at a college and really take very affordable therapy there. So that's the information that I've brought, and I am available by email or through the great group here. My email address I'm going to put in the chat is ambarr5@emory.edu. And these are the glasses that can be used for spatial neglect rehabilitation. If some of you are interested in learning more about that, I'll put a link in the chat to a YouTube video that I made a long while ago. I encourage you to look at it because I made it about 6 years ago, so I look a lot younger than I do now. So please feel free. And I'm going to turn it back over to our hosts. Thank you so much for making some time for me.
Thank you so much, Dr. Barrett. If you have questions again for Dr. Barrett, you can post them in the Q&A or chat. Dr. Parker, anything before we turn it over to Dr. Hartley?
Yes, Dr. Barrett, one more thing. Emory University has a rehabilitation hospital and they have rehabilitation doctors. How, if you're at the VA, how do we access those resources?
This is a really good question and really important. Sorry, I posted my email address. I posted it incorrectly. So I put it in the chat now and everyone should be able to see it now. So again, a good rule for rehabilitation is you can always come in and ask, hey, how would somebody get considered? Because oftentimes rehabilitationists are used to explaining to people how to get access. And, even there's an admission office right there and they can discuss with you a little bit. In general, there are folks who would interact with your medical professionals. So to be a patient to come in and stay in the Emory Rehabilitation Hospital, in general, people come from one of the other hospitals and they've been there just recently in that day or the day before. So oftentimes it's done between professionals by the social workers, but there are instances where the person says, for example, if they're on the stroke unit at Emory University Hospital, they say, I know that I want to go to Emory Rehab Hospital after this. Please, can you make sure to talk to the folks there? And then there are staff who are assigned for that. But if people want to email me and ask me questions about that, I can put them right in touch with the professionals at the Emory Rehab Hospital or at other rehab hospitals, because if they are distant from Emory, they might want to go elsewhere. And the VA also offers access to other rehabilitation hospitals in the community, and really need to self-advocate oftentimes for that.
Just one last thing on that note, the difference between a rehab hospital like Emory Center for Rehabilitation versus go to the local nursing home. I say nursing home because that's what they're called, but they're also, they say nursing and rehab facilities.
Mhm.
You know, what I think that going to the Emory Rehab based on what you're saying would be better, but how do you know? Because you're telling people something they didn't know.
Absolutely. I'm going to just write down the name of the kind of facility that Emory Rehab Hospital is in the chat. It's called an inpatient rehabilitation facility. And it's basically a difference between, for example, going to a community hospital if your kid has, a serious disorder, and going to Children's Hospital of Atlanta, to CHOA, to a subspecialty hospital. In the inpatient rehabilitation facility, you have special therapists, people who've been trained not only to do rehabilitation, but for example, to do brain injury rehabilitation, stroke rehabilitation. So they have what are called these lines of rehabilitation service that are well developed. Anybody who's certified as a license as a therapist can practice in a general way, but not every physician is a neurologist. And in the same way, inpatient rehabilitation facilities have those specialists. They also have more physicians. So for example, if you have a stroke, they would have not only a general physician, but they would have a neurologist, and you get those two people for the price of one, helping with your care.
Thank you, Dr. Barrett. And would you please introduce Dr. Hartley?
All right, well, I'm going to give her a brief introduction, and I'm going to ask her to give more of an introduction. But Dr. Hartley is a speech language pathologist who is doctorally trained, and she's been working in the area of brain injury, and especially traumatic brain injury, for a number of years at some of the most distinguished centers in our country. And she's very well trained in not only the general approaches, but the sophisticated approaches, the advanced placement approaches that we have available for brain injury, for mental and aphasia language function. And Dr. Hartley, if you'll tell us a little bit more about your specific training, that would be wonderful, so that the audience can really have a good sense.
Okay, thank you for that introduction. And I'm so happy to be a part of this presentation today to inform people a little bit more about communicating with persons with dementia. My PhD is in speech pathology and neuropsychology, and I specialize in working with adults who have cognitive and language deficits. And so I have over 45 years of clinical practice. I've also taught at several different universities as well. But I try to really help people understand what their brain is doing and how their brain is operating so that they can function the best that they can in their everyday lives. And so today we're going to talk about dementia. And if I could have my first slide, and I'm just going to really talk kind of in some general guidelines, but I want to start by saying that, of course, dementia, because of the language and the cognitive deficits that are associated with the brain dysfunction, can affect communication in a number of different ways. Of course, people with memory problems and slow processing are not going to understand what you're saying to them at times. They may have problems coming up with the names of things that they want to say, or come up with ideas of what to say, so they can't tell you their own wishes and desires. They may have difficulty in social interactions because they can't read the social situation and determine how to interact in that particular situation. They have problems in organizing and sequencing activities. And so it becomes difficult for them to do some of their ADLs because of that, or to organize their home. They also have problems often in behavioral and emotional regulation. So all of these things affect the communication. But some general guidelines here is that people with memory disorders, very severe memory disorders, tend to be rather distrustful and anxious. So in any communication interaction with them, you want to maintain a sense of calmness and respect. So when you first come to the person who has dementia, you want to get their attention, you want to introduce yourself, keep your sentences short and simple, and use a normal rate of speech rather than some real slow rate of speech. And you repeat and rephrase things to help them understand things. So if I were to come up to someone in a facility, I would say, I would sit near them where they can see me, and I would say, hi, Mrs. Smith. My name is Leila. I'm from the speech department. How are you doing today? How are things going for you? So I'm trying to, show respect by introducing myself and repeating my interaction and giving her a chance to respond. Also, because of the language difficulty and the planning problems, give them yes or no or choice questions rather than open-ended questions. Because they may not be able to come up with the words. If you say, what do you want to have for lunch? You could say, would you prefer a ham sandwich or soup for lunch? Would you rather wear this blouse or this blouse? Because giving them choices is very important where they can make their own choices. People in this type of situation have very few opportunities to have control in their life. They're told where to go and what to do. So time you can give them a sense of personal control, offer that up. It's also very important to use a normal adult tone of voice and to be very respectful in your body language and intonation. There is something called emotional memory. People with even severe memory problems can retain an emotional feeling about something. So a person with dementia may not remember that they have ever met you before, but they know whether they like you or they don't like you. And so it's important to always keep that in mind, so that look at how you're presenting yourself and be very respectful, because people with language problems tend to be overly sensitive and better able to read body language. So make sure you consider what you're presenting to them and how you're presenting yourself to them. On the flip side of that, it's important for you to read their body language, because often they aren't able to explain their needs, but there may be, if they're in severely into dementia, to explain that they have pain or need to go to the bathroom, or that they're hungry, but they may become restless or irritable, or seem very anxious. So learn to read their body language as well. And if I could have the next slide, to help with communicating verbally provide some visual material as a backup will be helpful, because reading is generally preserved, at least for short concrete reading, for quite some time with dementia. So you can post notes or signs in your environment. It's good to have a whiteboard or something right there where the person can see in their everyday environment what the calendar or activities might be for that day, or the schedule, or names of people that are there as caregiver, or what may be something coming up that they need to know about. You could put labels on drawers and cabinets for them. You can create a memory notebook, is very helpful. Early on, it may be an organization of all the information someone might need to live by, with their insurance information, their medical information, medications, doctors, their financial information, their computer procedures, and their passwords. But later on, it may be that it requires that you have a memory notebook that's just consists of the pictures and names of persons in their environment. So if they want to discuss somebody, ask you about their daughter, or ask you about their cousin or something, you have the pictures and the names that they can point to. Pictures from their history, from their past, things that they might want to talk about, other key information that would be helpful as you share things, even about basic needs, about a picture to go to the bathroom, or a picture about wanting something to eat, or that they're in pain, or that they want to see their doctor. Any of those things could help facilitate communication with someone with dementia. And on the next slide, I want to also highlight another type of preserved memory, even with dementia, is something we call procedural memory. And that's where you've learned to do something over and over through a series of actions, through a series of motor procedures. And if you think about it, when you first learned how to tie your shoelaces, you had to think of, step by step as you teach a child how to do this. But later, it's just a part of a routine. You don't have to think about it. And so if you can capitalize on things that are routines or establish good routines, you're going to have them function better for longer. And so establish and keep to a normal routine for the individual. So they get up out of bed, they put on their clothes, they have breakfast, and then they take their medication right after they eat. Well, they've learned that procedure. They don't have to rely on memory. That's just a set procedure. It's good to also have set times throughout the day that they're going to have nutrition, their meals, their fluid intake, going to the bathroom, having a shower. To stick to that routine, because there's greater acceptance when you're in a good routine. And that keeps their brain functioning at the best, because they're getting nutrition and things that are done for their body on a regular basis. You want to encourage them to do activities that they enjoyed before, and for you to participate with them, things such as singing or listening to music or playing cards. I know when my mother couldn't even talk with me as she became more deep into the dementia, we could sing hymns together, and she remembered the words to the hymns. Because that had been a part of her life for so long. So think of things where you can use those capacities and they can enjoy those things, and provide opportunities to do the things that they're capable still of doing, maybe sorting or folding the laundry, or putting away the silverware, folding napkins, and provide opportunities for them to socialize at whatever level they're able to do, and to include adaptive exercise to help with their brain functioning as well. That is all that I prepared for today, but I'll be happy to take any questions. A lot of the comments that I would make, depend upon the level of the cognitive and deficits that the individual has.
Thank you so much, Dr. Hartley. I have a question though. When you say it depends upon the deficits that the person has, how are we able to determine those deficits? Now, Dr. Barrett gave a really good talk about how you can access rehabilitation services, but I don't think that everybody really understands what's involved in that kind of assessment. So can you kind of take us through that, please?
The best assessment would be a neuropsychological evaluation because that looks at all areas of functioning, but that may not be necessary to have such a long test done with someone who's already been diagnosed with dementia. But a speech language pathologist could generally do the cognitive and language testing that is necessary for developing a rehabilitation program.
So for our audience, we know that Dr. Barrett is a neurologist. We know that you're a PhD doctor. So when you're talking about a neuropsychologic exam, I have referred a number of patients for this, and that's actually how I've gotten to the dementia diagnosis, because I have a black and white report that I can give to unbelieving family members. Are these neuropsychologic examinations something that somebody can access without a doctor referral? One. And number two, are these kinds of assessments paid for or reimbursed by Medicare?
They are, I believe, paid for by Medicare. And the ideal thing would be if you're going for an initial evaluation, to go to a center like Emory Center, where you have the neurologist and the neuropsychologist available to do all the preliminary testing and the medical workup that's necessary. Not everybody, has that available to them. But if they already come with a diagnosis of dementia, then with their doctor, they could be seen by a speech language pathologist. Dr. Barrett, would you like to add anything to that?
No, I think that's good. We can transition if you want to some of your other questions, or Dr. Parker, maybe you want to guide us.
There are a couple of questions.
Yeah, I'm looking, there's several really good questions in chat, and I think it'd be better for you all to answer those because you're the experts here.
So Dr. Hartley, Patty Bell has reported that her mom has dementia and lives in a memory care community. And she's highly functioning, but she doesn't want to get out of bed. Even after a meal or an activity, she wants to go back to bed. What are some things we can do to motivate her to get up?
It would be very important to find any kind of thing that she might cooperate with, whether that is, they usually like something that's social. So trying to figure out something where she might be motivated. She may be so depressed. And so talking to the doctor about looking at depression and can medication be of help, may be the trick there, because sometimes if it's not treated, it's hard to motivate them.
I have to really strongly agree with you, Dr. Hartley, because I've seen that sometimes people will develop depression who have dementia, and really people just assume that it's a reaction to the sad situation or their feelings, and don't realize how much more the person could be doing if they were treated for depression. We have some questions about the difficulty that people with dementia and Alzheimer's disease can have in finding words, finding names, remembering what they've done. kind of both the feeling of loss and kind of how we can bring forward daily kind of activities and enjoyment. What advice do you have for us?
Well, sometimes having a memory journal or creating there are different apps where you can have short videos, little clips for each day. And sometimes just by having some little back video clip for each day is enough to show to them, oh, I've done something each day. I've accomplished something little every day. Or just by writing a journal of different activities, looking back at that journal and giving them the sense of accomplishments and what they are doing with their lives, because they can't recall from day to day on their own.
Something I used to use sometimes, Dr. Hartley, is this little automatic camera people could wear called the autographer. Did you ever have one of those? They stopped manufacturing them, unfortunately,
Yes.
but they were great. And obviously people can just use their cell phone, but the nice thing about this little camera is you would wear it around your neck and you didn't have to remember to take pictures, but it would take pictures automatically if you changed your position or went indoors or outdoors, the temperature changed. And then a person who had difficulty with memory could have a whole string of pictures they took in that day. And let's say their loved one came home at the end of the day, they can review that string of pictures with them and really, have a joint experience then that is enjoyable without struggling for the words or struggling for an explanation.
Any
There's
more
a question
questions in the chat?
Yeah, there's another question about, oh, good. Jessica Coleman comments that she takes photos daily and it's very helpful. I think it's a great thing. And people have shown that if you review your pictures together, when one person has some difficulty with memory, that it is not only an enjoyable experience, but it may prompt really positive feelings and also some memory. Sheila Gregory asks us if there's a way to know if a person who is in the latter half of Alzheimer's disease or has dementia may be able to afford neuropsychological testing or access it. And there's another question about rehab, but we can get back to that. What do you think about that, Dr. Hartley, about?
Sometimes it's helpful for the rehabilitation person to be involved just to help the family understand how to better communicate with the individual and help with the whole behavioral issues that may arise too, because there are a lot of things in terms of cooperation and emotional functioning that happens there. So yes, and, at any stage it could be helpful. If the person is in assisted living or skilled nursing, there should be a speech pathologist that's available or someone that they could refer you to who could come to the facility. There are outpatient programs in speech pathology at any hospital that you could access the speech pathologist at any outpatient setting.
And the question is whether somebody would qualify. In general, these services, they're linked to people who specialize in looking to see if somebody's insurance or if their coverage is adequate, and would counsel if there's, if we're going to self-pay out of pocket, they would counsel us about how much that's going to be or whether can we pay over time, this kind of thing. And I think it is true, what you've implied, Dr. Hartley, is that sometimes I think people have an understanding that they may not like one family doctor, but another family doctor might be just the right fit for them. And they don't necessarily take that same kind of shopping to consumer shopping or empowered feeling to therapy. They may assume, well, if a physical therapist doesn't work with them, then no physical therapist is going to work with them. And it really is an individual thing, just like it is for a family doctor or any kind of practitioner.
Yeah, just like in any working relationship, you have to find someone that works well with you. not necessarily anybody else, but it's you shopping around to find the person that has the skill level, has that interpersonal ability to motivate you to get better and to help you.
Oh, thank you so much, Dr. Hartley and Dr. Barrett. I'm a family physician, and I really do believe that if a doctor you're going to isn't your cup of tea, or more importantly, isn't hearing what your concerns are, find another one. Okay.
Exactly.
You just find another one. So thank you both so much for your information and really educating us about rehabilitation, because I don't think that people always have a clear understanding of what that is. We're going to have you on later on in the year to talk some more about rehabilitation, but thank you for letting us know that occupational therapy is something that's advisable for all of us.
Yes,
Accessible.
occupational therapy, speech language therapy, physical therapy, and even other kinds of therapy like music therapy and recreational therapy, brain injury therapy. Let us know if we can be of more help to you, but we're looking forward to joining you again.
Thank you. Okay, Cornelia, I'm going to turn this over to Matt and let you finish.
All right.
Hi guys. So in a few minutes, we're going to be starting CEP Community Live. I will post the link to register if you're not registered. Today, we're going to be joined with Maureen. She is our service provider for functional independence, and we're actually going to be talking about some occupational therapy topics today.
Wonderful. What a great segue as we transition to our cognitive empowerment program. That's what we refer to as CEP. And that's a program on our Emory Brain Health campus at our Brain Health Center that if you have mild cognitive impairment, you can join them every week. They're offering this program at no cost to you, but they do have a very comprehensive program that you do have to go through a process and meet certain criteria if you want to be in their more intensive program. All right, well, thank you to our 200 plus individuals that joined us today. And I see we had 10 new participants. So again, every week, every Tuesday, I think there was some consideration for us to try to have a hybrid program in the fall. That's to be determined right now. We are moving in that direction, but if things change, we will keep you guys posted. But in the interim, we will continue to offer this virtual version of our Brain Talk Live. We will see you back here on next Tuesday at 2 p.m. We have a lot of great content lined up for you over the next several weeks. So stay tuned and head over to the Cognitive Empowerment Program. It is a different link than the link that you are currently on. It is via Zoom. It is via Zoom. So you need to grab that link right now if you can. Okay. All right. Well, thank you guys, and we will see you back here next week.
Come on, Matt, let's go. Come on, BA. Go. Did anybody put his cover back in the page? on.